Perfect. Welcome everyone who is joining us today. We will wait a couple of minutes until everyone can join to the Zoom. I see people are coming. Therefore, people are still joining, so we are just waiting a couple of minutes. Perfect. I think wait anymore. So welcome, good afternoon or good morning to everyone. Depends on place. Welcome, I am Zsófia Nagy from the European Pain Federation, and I will be here today with our wonderful speakers. Today's topic is pain in transgender and gender diverse populations. We will have two presentations, three presenters. Robrecht, Elise, and Katelynn are already here. Welcome. Thank you so much for your time. It's wonderful that you are here with us today. Please don't forget that we have a Q&A section, so you can just write your questions or comments there, and in the end of the presentations, we will give a bit of time and space for the questions, and you can ask from the presenters. First, I would like to start with a brief introduction, and I would let you to introduce yourselves. I don't know who wants to start, but Robert, you are the first one for me on the screen. So could you please start to introduce yourself?
Yes, of course. My name is Robrecht. I have a background as a biomedical scientist, specifically in neurosciences. And I've started my PhD a little over a year ago, where I study stress and pain interactions, but I also focus a little bit on gender and pain interactions together with Elise. So that's kind of my background. And maybe also important to mention is that I use any pronouns. So you can refer to me in any way you'd like.
Thank you so much. Elise, would you like to continue, please?
Yes,
Thanks.
for sure. Thank you. I'm Elise. I graduated 9 years ago as a physiotherapist, and I've started my PhD about 4 years ago. My PhD subject is the interdisciplinary treatment in chronic pain patients, and I'm also still clinically active where I treat, of course, chronic pain patients. Thank you.
Wonderful. Thank you so much. Katelynn, welcome.
Thanks so much for having me. My name is Katelynn Boerner. I use she, her pronouns. I'm joining you from the west coast of Canada in Vancouver, and really happy to be here today. I'm an assistant professor in the Department of Pediatrics at the University of British Columbia, and also a psychologist with the Complex Pain Service at BC Children's Hospital. Thanks for having me.
Thank you so much. Thank you for being with us, and we have already our slides here, so I will give you the space and the time to start with this topic. Hopefully everyone arrived, so I think, Robrecht, the floor is yours.
Thank you so much. Everyone can hear me all right? Okay. So welcome everyone. Thank you so much for attending this webinar. Also, thank you to EFIC and our host for accommodating us. Elise and I will be sharing some context, data, and possible mechanisms with you today surrounding pain in transgender and gender diverse populations. So we already did a small introduction. So maybe also important to mention is that Elise and I are calling to you from Belgium, where Elise is calling from Ghent University, and I am mainly working at the Vrije Universiteit Brussels. Today, we will first be providing you with a short introduction into the topic and some basic terminology, but also some deeper context for the topic, after which we'll continue with some basic findings on pain prevalence in gender diverse populations. And after that, Elise will take over and continue with some studies on gender affirming therapies and possible mechanisms behind our findings. So first, let's get the basics out of the way. So two terms are very important when we're doing this webinar to kind of see what we are talking about exactly. So to this day, most research publications do not adequately discriminate between the use of the terms sex and gender. So important to note is that the World Health Organization, or the WHO, defines sex by biological factors like genetics, hormones, or reproductive anatomy. And based on these characteristics, individuals are often classified as male or female. However, so-called intersex variations prevent the category of sex from adhering to a strictly binary classification. On the other hand, you have gender, which according to the WHO involves attitudes, feelings, and behaviors a specific culture associates with a person's sex assigned at birth, and is generally considered to be socially constructed. However, we must be careful not to kind of promote a false dichotomy between these two concepts, because more and more it is being discussed that sex is not a strict or objective biological substrate on which gender acts, but that they are more intertwined than we initially believed or classified them to be. Then transgender individuals specifically are individuals who temporarily or permanently experience an incongruence between the sex that they were assigned to at birth and their experienced gender identity. So, for example, a transgender man is an individual that was assigned female at birth but identifies as male, while a transgender woman is a person that was assigned male at birth but identifies as female. And as opposed to this, cisgender individuals' sex assigned at birth aligns with their gender identity. However, transgender is an umbrella term that encapsulates more than just opposite gender binaries, but also identities outside of this binary, like, for example, non-binary individuals. Then lastly, the term gender diverse, as is used in the title of this webinar, is used to describe gendered individuals that fall outside of cisgender norms, both in terms of gender identity, but also gender expression, for example. So a little bit more about the terminology involving gender. It's a bit complex, but I'll guide you through it. So gender identity can be defined as the aspect of self-identity that exists in relation to the gender one feels most connected to. And we specifically like the idea of gender identity being the incorporation of gendered meanings into a sense of self. Historically, there are two traditions when it comes to gender identity. One with a kind of external assessment based on feminine or masculine attributes, and another that is more internal, that kind of goes off of self-identification or self-categorization of subjects. In addition to this, you have gender expression, which encompasses behaviors and aesthetics that the outside world seems to associate with gender. And this mostly aligns with your gender identity and how you try to communicate this to the outside world. But this is not always possible due to certain contexts, for example, due to safety concerns. So even this gender expression as well is something fluid, context dependent, and not necessarily congruent with gender identity. And then how these behaviors, expressions, aesthetics are interpreted is informed by gender beliefs, which are in short associations of those behaviors that a certain culture has with a particular gender group. And it's important to note that these gender norms are often constructed through past and current power relations in society, and that they are in that way informed by sociopolitical structures. So now a bit more about the specific context of gender and pain. There has been a lot of studies on sex and pain, but gender and pain is a fairly recent field of study. And a very important to us article or suggestion is the gender context model of pain. By Edmund Kia. And this model actually centers gender identity and builds other aspects around this concept. So all these relationships around gender identity create a cyclic and bidirectional dynamic that are relevant for the experience and processing of pain. Two very interesting phenomena within this model are, first of all, gender role conflict, which is when a pain a person experiences interferes with their ability to fulfill gender expectations. So a very easy, basic example to help you understand this, for example, when someone who considers themselves as a woman feels feminine, and believes that women should have a specific role in the household, but suffers from chronic pain, which causes that person to not be able to fulfill those household tasks, they will experience a gender role conflict. They will see that the pain that they experience is in contradiction with the gender role expectations they have for themselves or other people. And this can then also result in gender threats, which is the actual perceived threat to self-identity that pain can cause. And this is hypothesized to motivate people to restore their gendered self-identity by either resolving their painful experiences. So, for example, being less sensitive or becoming less sensitized to pain, or by either resolving that gender role conflict and letting go of certain gender role beliefs, for example. Now, onto some basic data on pain in gender diverse populations, just to give you an idea of what's out there or what is known already. First of all, multiple studies have observed a higher prevalence of pain in the pelvic region in transmasculine individuals, ranging from pain during intercourse or menstruation to more general pain as well, which seems to make sense intuitively in the context of gender dysphoria that this population could be experiencing. However, also on a broader scale, we see a higher prevalence of headache, for example, in the transgender population, not only in trans men, but also in trans women, indicating that the pain is not necessarily limited to gendered areas. The studies here that I highlighted on the screen also points to anxiety, depression, or consequences of discrimination as a possible cause for this higher prevalence of headache. And indeed, studies have shown that quality of life is significantly lower in this population, specifically highlighting how important pain, bodily pain, chronic pain is in this significantly lower quality of life. So now I will allow Elise to continue about gender-affirming therapies.
Okay, from now on, I will take over and I will start with giving you a state of the art regarding gender-affirming therapies. Gender-affirming therapy has become a very valuable intervention for those individuals experiencing gender incongruence. The misalignment between one's gender identity and outward expression may intensify pain experiences, so the opposite, achieving gender congruence, may have a beneficial impact on pain perception. Next slide, please. If we take a look at gender-affirming hormone therapy, we see that research states that estrogen and anti-androgen treatment might have a negative influence on pain, so it will increase the pain, while the opposite counts for androgen treatment. This will decrease the pain. However, we saw in research that that is not always the case. For instance, a recent study showed that in a transgender women population that was pain-free prior to initiating estrogen hormone therapy, the administration of these hormones did not result in an onset of pain. This is a bit opposite of what I would have expected based on the earlier results I've just told you. The latter shows that gender congruence will also have a positive impact on pain experience. Next to hormone therapy, there exists a lot of research about gender-affirming surgery as well. And these studies mainly investigate transgender persons, and research into this population is very valuable as their results can give insights into the real role of gender identity. Why? Because, for example, a transgender women population, they have a similar biological sex at birth as cisgender men, while their gender identity matches the gender identity of cisgender women. So if we take a deeper look in studies on gender-affirming surgery, a trend emerged indicating that transgender men have lower pain sensitivity scores than cisgender women, and transgender women exhibit similar pain sensitivity as cisgender women. So, I think these findings impose that not only the sex assigned at birth has an influence on pain, but gender identity has something to do with it as well. We noticed that most pain research in a transgender population focused on these two medical treatments. However, hormones and surgery are not the only gender-affirming therapies. So I just want to point out that there exist other gender-affirming therapies, such as chest binding. Chest binding, which is the therapy for masculine gender expression among people assigned the female sex at birth. In chest binding research, there is not a lot of pain research done yet. So there's still a lack of pain research. Next slide, thanks. Now I would like to go a bit deeper with you all and give some possible hypotheses which can explain these rather unexpected results. I would like to first go back to the gender context model of pain. So I will repeat, this model posits that pain can pose a threat to gender identity, potentially creating conflicts with gender-related values and beliefs. So, conversely, it is plausible that gender-affirming therapy, by reducing the sense of gender threat and alleviating gender role conflicts, may subsequently lead to a positive impact on pain, a reduction in pain. So we believe that the hypothesis proposed in this model can be confirmed with some of the results that I've just went over. Firstly, gender identity may play an equally or even more significant role in pain experience than the sex assigned at birth. Focusing solely on sex assigned at birth constrains the understanding of pain to only its biological dimensions, overlooking the complex interplay of psychological and social factors. Secondly, gender congruence, which is enhanced through the use of those gender-affirming hormones or gender-affirming surgery, may reduce gender threat and gender role conflict by achieving a closer alignment with one's preferred gender. And this can have a positive impact on the pain perception. However, if that alignment is an intrapersonal phenomenon, or rather an alignment of the environment, that's still unclear. So perhaps there is no such dichotomy to begin with. As pain is widely recognized as a biopsychosocial phenomenon, it seems crucial for us to incorporate gender identity into the pain assessments to achieve a more comprehensive understanding of pain. However, we feel that there are currently no very valuable instruments or validated instruments to measure gender identity and gender roles in relation to pain. And that's a bit where Robrecht and I will focus on in the future. Given the scarce literature on pain experience within the gender diverse population, and the majority of those studies focused on transgender individuals, I also want to underscore the need for future research to assess a broader spectrum of gender diversity, extending beyond the transgender population. So, to close off, on behalf of Robrecht and myself, I want to express our sincere gratitude for your participation in this webinar on gender diverse populations. I think, or we believe in these challenging times, especially with the recent political events, it's very crucial to continue advocating for the rights of the gender diverse populations. So please, let's stay united in our fight for equality and understanding. Thank you, and I would like to give the word to Katelynn.
Thank you so much. Yeah.
I'm just going to share my slides here. Hopefully everyone can see that okay. Thank you so much for having me, and it's such a pleasure getting to follow that really wonderful overview of some of the core concepts that we need to understand to be able to appreciate some of these unique pain experiences and considerations for transgender and gender diverse populations. My work is specifically in pediatrics, so I focus primarily on adolescents, and I'm going to share a little bit about some of the work that we've been doing looking at pain experiences in gender diverse youth, and how there are some developmental considerations that are important for thinking about in terms of how we're understanding the problem of pain in this population, and how we might approach things like doing ethical research with these young people. I just want to start with a brief acknowledgement that I am reaching you today from the ancestral and unceded lands of the Musqueam, Squamish, and Tsleil-Waututh nations. This is a common practice now in Canada as part of our efforts towards truth and reconciliation to acknowledge the traditional lands that we are speaking from anytime we're giving a presentation. And I also just want to highlight that as some context as well. I think Elise just noted that there is really an importance in considering sort of the socio-political environment that one is conducting research or providing care in, and how that might impact the folks that we're hoping to serve with our work. And so I give this land acknowledgement as part of my own efforts towards truth and reconciliation, and considering the socio-political climate that gender diverse youth are navigating here in Canada. So we know that pain is not the same for all people. Pain is what the patient says it is, and pain is a highly individual experience. And I think the overview that you just heard really emphasizes the importance of considering individual variability and individual identity factors and social positions in understanding one's pain experience. And when this comes to pediatric populations, it's especially important to understand how those identities intersect with developmental stages, and how the influence of things like sex and gender can shift and change over the course of a young person's development. In terms of what we know about sex differences in pain responses really become apparent following puberty. So once young people reach early adolescence and start to go through puberty, this is when we see much higher rates of both chronic pain as well as experimental pain and acute procedural pain in individuals assigned female at birth compared to individuals assigned male at birth. And some work that I was involved in a number of years ago with the University of Bath found that there are also some sex differences in pre-treatment presentation between assigned males and assigned females, as well as treatment outcomes following psychological therapy for chronic pain. So we have an emerging evidence base that suggests that sex is certainly important, and the fact that these differences are more apparent following puberty has led to a lot of speculation about the potential role of hormonal factors. But we also understand that sex differences, I say maybe here on the slide, but I think you can say likely are multifactorial and intersect with gender. And gendered socialization, as it relates to pain, really begins from very early in life. So even though we don't see these reliable differences until puberty and beyond, We know that parents respond differently to the pain of boys and girls. There's also assessment biases that are present long before any reliable sex differences are present. So clinicians and other adults are assessing the pain of boys as being higher than the pain of girls. And work from my PhD thesis found that there is a differential impact in terms of social modeling. So how young people, younger children are impacted by having viewed a parent experience pain that has a gendered effect as well. This is a framework that myself and some colleagues put out last year that really was aiming to take this developmental perspective in looking at all of the different factors that might be influenced by sex and gender over the course of development, leading to differential health outcomes. And in the paper, we go into kind of how this relates to child health more generally, but then we also use pediatric pain as a very specific example. And so you'll see that even from as early as conception, that there are potential sex and gender influences on the eventual development of pain. And we've situated all of that within this overarching framework of social positions. So this is really about taking an intersectional perspective and considering that when we're thinking about things like sex and gender, it's also very important to be considering things like culture, race and ethnicity, socioeconomic status, that an influence of a variable like gender identity can be very much driven or informed by other contextual factors that the young person is living at the intersection of. And you'll see that, puberty and all of the biological and psychosocial changes associated with it is on there, but there's a lot of other factors that lead up to that point that might inform the expression of sex and gender differences that we see at later stages in life. So how does this all relate to the pain of transgender and gender diverse youth? Well, we know from some recent work that there's higher rates of pain and stressors in trans and gender diverse youth compared to cisgender girls and boys, and that many of those stressors may be occurring at earlier developmental stages. Sexual orientation or gender minority discrimination is associated with higher rates of chronic pain in children. So being exposed to discrimination on the basis of your sexual orientation or having a minoritized gender identity. And work looking at the impact of an interdisciplinary pain treatment program specifically on gender diverse youth compared to cisgender youth found that there was increased distress and impairment among the trans and gender diverse youth when they entered the program, but that they had similar responses to the treatment program as cisgender youth, but also higher rates of non-completion. So I think what I really like about that study is that I think it highlights the importance of looking at more than just treatment outcomes, but also engagement and potentially kind of safety and comfort level with the treatment environment. And some qualitative research that came out a couple of years ago really talks about the impact of living at the intersection of two minoritized identities. So there's a lot of stigma associated with living with chronic pain, and that ableism or sort of anti-disability sentiments are one type of stigma that young people are dealing with, but then also this concept of cisnormativity, where the assumption is that being cisgender is the norm and everything else is a deviation that the environment has not accommodated for. And you can completely understand how just living with one of those types of discrimination could be extremely stressful, but living at the intersection of both and navigating both is a significant stressor on young people. And we know that stress is a really important risk factor in determining who develops chronic pain. So it's a really small but emerging area of literature. And I think there's a number of factors that I listed on that previous slide that we know is relevant to the development of sex and gender differences in pain outcomes, but that hasn't been sufficiently studied in trans and gender diverse youth. Just to give sort of another conceptual framework to be thinking about in relation to this population, this is a socio-ecological model that we put out about 2 years ago now, speaking about gender diversity and chronic pain, specifically as it relates to youth, but actually I think really everything here is pretty relevant to any age group. And what we've tried to highlight within this model are some of the areas that we hypothesize to be related to the development of chronic pain or the maintenance of chronic pain in trans and gender diverse youth. And you'll see that there's a number of factors within this model that aren't specific to trans and gender diverse youth. They're kind of general factors that we know to be related to the experience of chronic pain. But the way that those factors may be experienced in trans and gender diverse youth might be different. And then there are some additional considerations within this that are relevant that to trans and gender diverse youth, specifically around things like gendered expectations. And one piece that I really like to highlight is the fact that, we often think about all of these risk factors as being particularly, negative things, but actually one of the important pieces we talk about in the paper is that there's also positive gender-related factors that might be relevant for trans and gender diverse youth. And in the project that I'm going to speak about next, I'll talk a little bit about how we investigated that. So it's very exciting to be able to talk about this project specifically because the paper just came out earlier this month in the journal Pediatrics. And so if you're interested, I would encourage you to read it because there's a lot of richness in the data that we collected that I can't go into detail about today, but I would really encourage you to take a look at the paper. So this was a qualitative study that we conducted aiming to look at the experiences of chronic pain in trans and gender diverse youth. And just to give a little bit of context, this picture here is from just outside of Vancouver. So I'm situated in a very beautiful part of the world and encourage everyone to come visit. We recruited youth within the province of British Columbia, which is a large geographic area and encompasses many rural and remote communities. We did all of our research virtually, so participants could engage with us from anywhere. They just had to be between the ages of 13 and 18 years, identify as trans or gender diverse, have chronic or recurrent pain that had lasted for 3 months or longer. They had to speak sufficient English to be able to participate in an interview. And we recruited very broadly. So we recruited within our clinical settings, both our pain and gender clinics, as well as some other clinics here at the hospital that serve young people who experience chronic pain, but we also reached out to a lot of community-based organizations and did recruitment through things like social media because we really wanted to hear about the experiences of a diverse sample of youth, not just those who had access to a tertiary care hospital services. And I think that actually ended up being quite an important approach for us. We've put a lot of thought into the methods for this study, really wanting to create a safe and affirming and autonomy promoting environment for these young people. And we worked very closely with our institutional ethics board to come up with this protocol. We did an initial screening and provided participants information. We provided them the interview protocol ahead of time, so there were no surprises about what was going to be asked. We provided very flexible options for participation. So once their identity had been confirmed, participants were allowed to have their camera off. They could type responses in the chat if there was any dysphoria associated with their voice. And they could have a support person present with them. And we gave just lots and lots of choice about the environment that the interview was conducted in. We obtained consent from the young person if they had capacity to provide consent. This was another procedure that we worked really hard with our ethics board to be able to have in place, but we felt it was really important that if youth were able to, that they could provide consent to their own participation, so that we didn't require that their parent be aware of or in agreement with any aspect of their gender identity or presentation in order for them to participate. And there were a couple of young people who specifically gave us the feedback that if this hadn't been in place, they wouldn't have been able to participate because they weren't supported by their family and their gender identity. The interviews, as I said, were done virtually, and we collected data in 2021, 2022. And we did a reflexive thematic analysis to look at the qualitative data. And this was done by myself in collaboration, very close collaboration with a lived experience consultant who was involved in every stage of this project from design through to dissemination, and who co-analyzed the data with me. So I could provide sort of the researcher and clinician perspective, and they could provide the lived experience perspective on what we were seeing in the data. There were three themes that we identified from the data. The first was this idea that youth really had to fight for their experiences to be seen as legitimate. They felt that there was challenges around visibility, vulnerability, and validation. Many youth talked about feeling like they were living a double life, that they weren't able to be their true selves to everybody they encountered, and that this impacted the way that they showed up in healthcare encounters. And despite the fact that their identity was often questioned or invalidated, they were also placed in this unwanted expert role where they were expected to explain a lot of the nuance and considerations related to being transgender or gender diverse to their healthcare providers, even though that same provider might be simultaneously invalidating their identity. So one quote from a youth in our study said, being a youth and being queer, everyone just questions whether or not I know myself or if they know me better. So as soon as I go outside of what they expect a boy to do, they're like, okay, now, were you really a boy? Because you're in pain and boys don't feel pain. Get over yourself. And so I've gone out of my way to stop vocalizing my pain and just simply live with it, just so I won't be questioned on if I know who I am. Our second theme related to this idea that youth were caught in a bind between being able to affirm their gender identity or manage their pain, but that it was really challenging to do both simultaneously. Some youth talked about sort of the embodied experience of gender and pain, and how the experience of living in a body that didn't feel right to you and living in a body in pain can be a very distressing experience. This quote here, I think, really speaks to that. This young person said, for people who do experience like body dysphoria, having your body be like sort of a consistent source of pain, their body is something that they have to be actively fighting against a lot in order to do things. And that kind of makes it hard to feel at home in your body a lot of the time, I think. A lot of young people also talked about adopting gendered pain behaviors as a means of affirming their identity. So trans masculine youth would talk about really making active efforts to hide their pain and to be stoic, because if they wanted to be seen as masculine, that was what was expected of them. And the really interesting thing is that a lot of these youth had a tremendous amount of insight into gender roles relating to pain, and how pervasive they are in society and where those roles come from. And many of them would actually say, like, I don't actually believe this. I don't think that this is helpful. I know that this makes it hard for me to affirm and treat my pain. But if I want to be seen and have my gender affirmed by the people around me, then I still need to buy into these roles, even though I think they're ridiculous. So I thought that level of insight was actually quite fascinating. And doing these interviews, you know, it was like interviewing a group of like 19 gender and pain experts. These youth had obviously thought a lot about these issues, which was helpful for us from a research perspective, but then also raises the question of like, why are they having to think about this so much? And it's because they're constantly placed in environments where they're having to navigate this really tricky balance of what aspects of my identity do I share with other people? And is this a safe place to do so? And how do I balance my pain needs and my gender needs simultaneously? The one really positive story, I think, to come out of this theme that I alluded to earlier is what we're calling the untapped potential of gender euphoria as a buffer against pain. So quite a few young people who had had the opportunity to experience gender euphoria, gender joy, or positive experiences of having their gender identity affirmed, talked about that as being a buffer against their pain experience. That really helped to mitigate the pain that they felt. And that often was was a really important trade-off, that their pain was way more tolerable if they could affirm their gender identity. And I'll just mention, without going into too much detail about it, Lisa mentioned earlier the idea of chest binding, and that came up a lot within this theme as specific descriptions of how young people were caught between needing to engage in chest binding as a part of their gender affirmation, but finding that the methods they were using for binding, especially if they were sort of unsafe practices, they didn't have access to proper materials or education about chest binding, was a pretty significant source of pain. But then on the flip side, for young people who were not able to bind, they also talked about significant musculoskeletal pain related to trying to hide their body. So it's a really challenging thing for these young people to navigate. And then our final theme related to the idea that there are intersecting identities and social contexts that is really important to consider when we're understanding how these young people are navigating gender and pain. One of the big ones that came out was how pain and gender intersect with neurodiversity. About a third of our sample self-identified as being neurodiverse or autistic. And we know that in both pain populations and in gender diverse populations that neurodiversity is overrepresented compared to the cisgender population or the pain-free population. And a lot of young people talked about how that was a really important piece of their identity, that without understanding the impact of, say, sensory considerations or challenges of social interactions on their pain, you weren't getting the full picture. And the idea that having safe spaces and people that appreciate those intersections made a huge difference. So sometimes young people would talk about, having access to proper chest binding materials, having spaces where they could talk about their experience with other people who actually understood it. And also things like having access to a gender neutral, accessible washroom was another example of kind of navigating that intersection and needing the social context to be able to adapt to these young people's needs. So, in conclusion, when we were talking to young people about what they needed from a healthcare interaction and in receiving pain care, what they're asking for is actually not that complicated. A lot of young people are just asking for respect, asking for their voice to be heard in decision making, and asking for pain providers and professionals to do a little bit of education for themselves so that it's not solely on the youth to educate their provider about gender diversity. I think it's also really important to consider that trans and gender diverse youth are not a monolith. We struggled a lot with the fact that we lumped a lot of different identities together within this one sample. We had non-binary youth, as well as binary and identifying trans youth, as well as youth who had a number of different gender identities, and youth who didn't want to label their gender identity as they were still exploring it. And these are all very different experiences in terms of what it means for that individual and how it might impact their pain and their pain management. So I think that's really important to consider as we continue to move forward in the research that, as is true for many groups, it may not be appropriate to paint all the youth in this group with one brush. There were definitely overlapping concerns raised that cisgender youth also experience, but these intersect with minority stressors in a way that's really important to consider for the needs of these youth. There were some specific pain concerns. Binding is one of them that are important to make sure that we've got more research on and more education on. And a lot of my upcoming work has an increased focus on neurodiversity as a really important consideration for this group. And I'll just wrap up by saying, you know, taking on a project like this, I recognize is not within everybody's area of interest or scope. And so I just want to put a bit of a plug in for this paper that I had the privilege of being involved with that was led by Lauren Harrison from Stanford. It's coming out soon in Pain, and is really a call to action, but also some really tangible sort of best practices around the assessment, like very basic assessment of sexual orientation and gender identity that can be incorporated in any research in pain, just to begin to collect more inclusive demographic information. So even if this is not your primary area of research, I would really encourage just looking at this paper to get a sense of how you might even just revise your demographics form to take a more inclusive approach and to begin collecting some of this data in an affirming way. And I'll just finish by saying thank you so much for having me. Thank you to the different programs that funded this research, my collaborators, our community partners, and most of all to the young people and lived experience consultants who worked on this project with me.
Thank you so much, Katelynn. Thank you for all of you for the wonderful presentations, and congratulations on the researches, what you have done. And yes, we have a couple of minutes for questions. We have the Q&A section, so you can write your questions there. We still have a bit of time. I think there is no question, but until that, I ask a couple of things. So what about best practices and guidelines? As you said, Katelynn, we need them. Are there any for patients? And are there any specifically for adolescents or for young patients?
So in terms of just the assessment of gender identity, that paper that I pointed to is a good place to start. And we draw a lot from work that was done by the Trevor Project, which is an organization based out of the US that does a lot of advocacy for LGBTQIA+ youth, and has done a lot of research on how to appropriately assess both gender identity and sexual orientation, as well as other factors. So that's a really great resource. And the thing that's challenging about all of this is that it's evolving, and our knowledge of terminology is evolving, our knowledge of available gender affirming care is evolving, and so, you know, I think in some ways it's very challenging to always know what the current best practices are, because they're always shifting. But I think we can, you know, try to do the best we can with the information that we have. And certainly in terms of guidelines for things like treatment and kind of more clinical considerations, there are guidelines that exist. They're often very discipline specific. I've seen a lot of work being done in gastroenterology around best practices, in sort of gynecology, pelvic pain. There's, you know, some clinical guidelines, but a lot of it is really based on clinician opinion, and we just don't, in many cases, have enough research to be able to say conclusively whether those guidelines are truly evidence-based yet. So there's a lot of need for more work. I don't know, Elise and Robrecht, if there's anything you would add to that.
Thank you so much. In the meanwhile, there came a couple of questions. I will read it. So there is someone who works in palliative care, and how do you see these findings in relations to pain treatment in terminal stage in life? What should we be special aware of?
Oh, I saw you both unmute. I'm just going to put a link to an interesting paper in the chat that addresses this.
Perfect.
Yeah, I think it's a very niche topic and one that hasn't been explored a lot yet. I'm very curious to see what Katelynn will be sharing as well on resources. But I do know that as Katelynn already talked about intersections like neurodiversity or the intersection between ableism and cisgender normativity, there's also such a thing as the intersection with age, and there's a lot of interesting literature more in the cultural studies field on the intersection between pain, aging, and being queer at the same time. But I think it hasn't quite reached the experimental studies or the more quantitative research. But I think it's something very interesting to explore as well. Yeah, but as I see, Katelynn already shared a case study.
Thank you. I think there were a couple of other questions in the chat. Is there any relation of pain contribution with identity conflict?
I'm not perfectly clear on what is meant by pain contribution, but what I can say is that, of course, the relationship as Elise and I framed it between gender identity and pain is, as we understand it, to be a bidirectional one. So in the sense that gender identity could possibly influence pain experience and processing, but it also works the other way around in the sense that phenomena like that gender threat do result in gender identity could be formed by pain experiences. So I think if that is meant by saying pain, the relation between pain contribution to gender identity, I'm not sure. For example, there were some qualitative studies in the Nordic countries, mainly Norway, where men reported that due to their chronic pain experience, they identified less as men and their masculine identity weakened. So in that sense, there is also a contribution of pain to gender identity, just like it would go the other way around as well.
Thank you. There is another physiotherapist question. I would like to know if you can suggest some strategies to validate people with chronic pain.
I would like to answer that one, but mainly from my role as a clinician. I see validation in chronic pain is a very, very, very important part, and it all starts with making the patient feel welcome and let them feel heard. So I just take enough time so the patient can give their story, their history, what they want to share with me. And I end with very open questions like, is there anything else that you still feel to share with me that I don't know yet? And sometimes there are very important parts of their story that are still coming up at that end. And I think that is because I make them feel safe. You kind of make a safe environment that they feel at ease to really share what they think about their own problems, what they think about the cause of their pain, what they think about their ongoing problems. I hope that's also a bit an answer to that question.
Yeah, I think that's a wonderful answer, and I guess the other thing I would add is also just allowing the individual to let you know what aspects of their identity or experience are important for understanding their pain and not making assumptions about that, because I see very commonly that when we have a patient come in who identifies as trans or gender diverse, that immediately there's a bunch of assumptions that this has, certain relationships with their pain experience, or that they've had, that they've experienced a lot of stigma and discrimination that is contributing to their pain. And I think it's really important to consider that, that those assumptions can be harmful and can really frame how we are interpreting somebody's experience and somebody's coping. And so I love what Elise said, that, like, really just offering the space for them to decide what they're comfortable sharing with you, and what aspects of their experience are relevant to be talking about. And some of that also, I think, an important part of validating is like supporting somebody's autonomy and deciding what they do and do not want to share with you. And it might be that in a first visit, a bunch of invasive questions about their gender identity might not actually make for a validating or affirming environment.
Thank you. I think we have a couple of minutes and 2 questions, so probably our 2 last questions, unfortunately. So do you have any specific pain scores available for this population?
I think, yeah.
Yeah, specific pain scores, I don't know, but I do know, well, I've went through some research about quantitative sensory testing of trans folks, where they do measure pain sensitivity to thermal stimuli, to pressure stimuli, and they compare with the cisgender population. So I can forward that research if that's the question, but I cannot give specific numbers. That's a bit difficult, and it's very individual. So I don't know if you can just say, that's the trans population's pain score, and that the cisgender. I think it's a bit more complicated than that.
Thank you. And the last question was, do you have experience with nerve blocks for chronic pelvic pain and transgender patients?
Well, me definitely not, because I'm not even a clinician. But what I can do is maybe we can provide some resources after the webinar through mailing, for example, and we can send you the publications, because there are certain groups out there that really focus in on pelvic pain in transmasculine individuals. It's a very hot topic within this small research field. So maybe we can, by sending those publications, we can redirect you to the people maybe more adequately equipped to kind of share experiences with that. But I haven't seen any publications directly about that specifically.
Thank you. Thank you so much. I think we have done all the questions and answers. I mean, I'm definitely having other questions, but I think our time is over. So thank you so much for your time, for your participation, for the wonderful presentations. It was really nice to meet you, and it was really lovely to hear your researches and all your presentations. Thank you for being with us and give us your time. And thank you for everyone who participated today in our webinar. Please follow EFIC. We will have other webinars, hopefully, in this type of wonderful topics. So thank you so much, and have a lovely evening, or have a wonderful day, Katelynn. Thank you so much. Bye, everyone.